Good afternoon, and thank you for choosing to listen to us. Just briefly, we'll be finished by 5 to 1 at the latest, so you have your lunch sorted. Just briefly introduce where we're from and who we are. My name's John Griffiths. I'm a mental health nurse by my background, so please forgive me that in this current situation. Don't hold it against me. And I'm a ward manager in a mental health medium secure unit in South Wales. It's a forensic unit. We deal with adult 18 up to sort of 65, 70-year-old men and women who've offended through the criminal justice system as part of the mental health. They come to us for treatment. This is my colleague, Dr. Bronwen Davies, who is a learning disability nurse by background and a psychologist and all sorts of other things in between. What we come here today to talk about is our attempts to introduce a PBS model within our service. So I'll quickly just talk through what our service is. Casual clinic, it's in a Bridgend town called Bridgend in South Wales. I don't know if you might have heard of it. 5 wards in total. It's a fully commissioned service, dedicated service. It's the only NHS medium secure service in South Wales. There's 2 NHS services in whole of Wales, and with one that covers South Wales. So we have 5 wards. The clinic itself and all the wards are named after coastal towns or coastal areas around South Wales, so that's where the names come from. Penarth ward is our male intensive care unit, it's PICU. We've got Tenby ward, which is our admission and assessment ward. I'm currently the ward manager for that ward. Ogmore Cardigan ward, a very similar continuum care, pre-discharge rehabilitation for up to 14 male patients at a time. And then we've got Newton ward, which is our admission, assessment, pre-discharge, PICU, everything rolled into one for our women's service, and they have 11 beds. Why PBS then? Well, basically, as is the want of a lot of our patients with pro-criminal, pro-antisocial, anti-establishment, anti-care views and values, we had a lot of challenging behaviour, a lot of episodes of destruction directed to staff, to themselves, to the environment. So we looked at ways to try to manage that. So we looked at PBS. On the ward that I was managing between January and 2008 and June, we undertook just a quick sort of research into how many incidents we'd had. 51 in total, 30 undertaken by one individual in particular, sort of repeat incidents coming from that service user. Roughly then, nearly 60% no identifiable trigger. Of the rest of the identified triggers, the biggest was that person's request not being met. Timescales, Friday afternoon into Friday evening was most likely, and again, some theories around why that was: post-clinical team meetings, requests not being met, unavailability of staff to provide activity through the weekend. We also found out that our male staff are 3 times more likely to be assaulted, and our unqualified staff were twice as likely to be assaulted than qualified staff. Again, there's some reasons behind that, which we can go into if you have time at the end. Our most common response to incident was the use of PRN medication or physical intervention, the old CNR, RPIs, we now term it restricted physical interventions or safe holding. Probably not too dissimilar to any other service, I'd suggest in that respect. What we found, though, that we had an inconsistent and unstructured approach to managing the incidents that were identified. We sort of gave little thought upon how to prevent incidents occurring. We would try to formulate, but there was no real science behind what we were doing. It was based on clinical judgment. Previously, we invested a fair bit of time and money into a system called RAID. I don't know if you've heard of it. It's acronym for Reinforce Appropriate and We Implode Disruptive Behaviours. That was about 2005, and we had one ward, our PICU. All the staff were trained over a couple of days in this system. It's an approach based on differential reinforcement, so we reinforce the pro-social behaviours and we try to ignore the challenger behaviours. Being the NHS, being full of common sense, we then opened a 4th ward and moved all the staff from that one ward onto all different wards. Seemed a good idea at the time. So we diluted the critical mass of the skilled individuals. All the time and money we just spent in one area, we then shared out equally amongst all the other areas. So that skill and knowledge base was totally diluted. We have 5 clinical teams. 1 clinical team is dedicated to our female service. So we have 4 clinical teams caring for our male service users. They all have different approaches. So we don't have it a team per ward. We have all the wards, all the teams intermingled, different consultants, different psychologists, different nurses may have different views on how to manage our challenging behaviours. And it just becomes a little bit difficult to manage all in one area when you've got so many conflicting views. Obviously, the individual skills and abilities of the nurse in charge of each shift could dictate the approach used and the outcomes that were affected as a result of that. We always talked about we use ABC charts, we'll use functional analysis, we'll do all this. We tried to do it, we implemented it, but then it sort of fell short, so they weren't thoroughly analysed, or we didn't have the skills or knowledge to process what they were telling us. We'd failed to undertake them effectively, something else would happen, they may not be seen as a priority by a different nurse in charge or by a different clinical team. So there's a lot of confusion around what we were doing and why we were doing it. And we had, limited access to our clinicians with expert knowledge in managing challenging behaviour. So 3.5 years ago, we looked at implementing our first training system on PBS. So we had a discussion between our clinical nurse specialists who were CBT, BCP background, and our psychology department. It was formulated that PBS would probably be the best system that we could look to adopt, to implement, to train with. And that was based upon it being achievable. We had some in-house skills and knowledge and a level of sustainability. We had learned from what we'd done with RAID. We'd recognised we'd spent money and time, and then we disseminated that also. It was, if we're going to do it, we need to sustain it and make it achievable across all areas. We liked that there was a focus on the positive aspects of engagement and prevention of challenging behaviours, rather than it being a reactive state to trying to manage sort of events post-triggering events. Where cost wasn't an issue, it was just time. We had the in-house staff and expertise available. We identified key staff on the ward that I was implemented on at first, which was the ward manager, myself, charge nurses who had a little bit more training, a little bit more exposure to PBS, to the language, the systems, and we identified as link nurses, so our primary nurses, our care providers for our client groups could come and seek a little bit more support, a little bit more education, a little bit more understanding about what it was we were trying to do. Initial training occurred for all of our staff over a 6-week period by 2 psychologists. They had limited capacity to increase training. They still had their full workload. They had their full clinical commitments. So there was some difficulty to provide ongoing support. So it was still limited to one area, but we learned not to move the staff from that area. At the time, we were also fortunate enough to forge links with Swansea University. They were pioneering the practice innovation unit status and scheme for Wales, and we were, I believe, the first care environment in Wales to be awarded the practice innovation unit based on PBS and what we were doing. So following the training then, our multidisciplinary team management plans they developed, and we focused on green, the pro-social behaviours. That was the emphasis of what we were trying to do. We revisited ABC charts, revisited what functional analysis could provide with us, and invested far more heavily in understanding what the information that they held was. Certainly increased ward-based activities. That was something that our previous finders shown. Friday afternoon, evening, lack of activities, lack of input, more flashpoints. So we consciously tried to increase our activities through our OT department and activity coordinators, more in the evenings, weekends in particular, to give levels of activity and engagement. Key staff attended the nursing handovers. They would hold drop-in clinical sessions on the ward, so they were far more accessible and present actually in the clinical environment. And we encouraged use of red and green behaviours in the language. So the PBS language was encouraged in terms of our care planning, in terms of our assessments, in terms of engagement with our service users, our clients, in terms of our care planning. We undertook a review of the frequency of the clinical incidents post the implementation of PBS over roughly a 2-year period. Now, the previous 30 months had shown nearly 60 incidents of challenging behaviour or aggression. The year we started to implement PBS, we had 23, and then last year it actually dropped down to 3, which is a huge drop and a huge improvement in terms of the safety of our service users, the safety of our clinical teams. and the overall lived experience in the environment of our care areas. You know, it's, although not huge numbers in themselves, that drop I think is a wonderful thing for us to be able to report back on.
So that one service, is it right to interrupt?
Of course.
So that one service user who was responsible for 60 they're still on the ward?
No. If we knew now what we should have known then, I don't think we'd have had those numbers. This particular service user was using violence as a communication that we just didn't understand. It was an instrument for him to communicate, and we just weren't understanding that. So what had happened, his care had progressed him out of the clinic. We were aware of some of the clues about it probably wasn't the best environment for him. Some of it was iatrogenic. We were causing some of those issues, so it was identified a better suited environment, and he's progressed really well in that. So a lot of it was what we were causing through naivety, lack of knowledge, lack of understanding. If we could go back knowing what we know now, I'd hope and fully expect we'd have different outcome measures for that. Some of the major barriers we've encountered, and it's no coincidence I put staff attitude at the top, is staff attitude. Some staff, query a lot, believed we were rewarding challenging behaviours, or that the staff individually felt that they were being manipulated by our service users. Comments of there must be a consequence to this, that punitive basis of their mind. There must be an adverse outcome for that person. How dare they do this to me? They shouldn't be allowed to get away with this. We would have incidents of aggression or some destructive behaviour or an act of deliberate self-harm, and we were looking to understand why that was through frustration, and if we could alleviate that frustration by taking somebody on a leave, by giving them some type of pro-social interaction, we would diminish that causation behaviour. A lot of staff saw that as rewarding that behaviour, just reinforcing, well, if you treat them nice now, they're just going to go and cut themselves again. So there's a lot of educational challenges for staff, and to some degree that is still ongoing. So limited initial training. Again, going back to our RAID approach in 2005, the focus was only on one ward at that time, our PICU, our male acute intensive ward. Service users and staff moved. More importantly, it was probably the service users were moving through the wards. They'd be coming to us, we'd stabilise their mental health, stabilise their levels of engagement. They would move through our system onto our other wards. PBS wasn't there. So some of those challenges to their behaviour just re-emerged because the framework around them wasn't in place. Yeah. Some lack of consistency still in us following care plans. It was a small service group. It was only 8 patients as the maximum that ward could hold. Not all of our patients, our service users at that time, needed to have PBS plans. They weren't all presenting with challenging behaviours. So it led to some inconsistent decisions and still some ongoing inconsistent team approaches. And we were left with a feeling of what next. We'd seen it being effective, and one gentleman in particular, which we probably haven't got time to reference through this, it was incredible the outcomes that we managed in terms of a challenging behaviour. But it's seen as what next? We've done this. There must be more to this. We can see it works. We can see we can reduce incidents. There has to be something else. And again, it's recognised that we had limited capacity of our psychologists to provide ongoing training and support towards staff. Wasn't this one there? No. Sorry about that. So the next steps then. Coming up to last, sort of nearly up to speed to where we are before we go into what we've achieved. The ward staff on Penarth Ward, which is our ICU 8-male bedded ward, was surveyed on their views, hopes, needs in relation to PBS. So it highlighted that staff were still trying to implement it. We were still wanting to use the red and green language, still wanting to be proactive and try to manage challenging behaviour in a better way, for want of a different word. Staff, though, often felt excluded from writing the PBS plans and wanted more input and development, so they had a better stand in them. It was still very much psychology-led, which is, no bad thing. There was a desire for more training, so some staff had not received any, whilst others had only received parts of training, not all of it. Staff had left, we'd recruited new staff. There was some lapses in the training that we had to fill in for everybody for a consistent approach. Those who had had the training a couple of years ago wanted refreshers. They wanted to revisit what we'd done. Our primary nurses wanted more support from other disciplines in promoting a PBS approach. a need for assessment tools, more accurate assessment tools that could be used to analyse challenge behaviour, so we could revisit the ABC charts, better understand what they were communicating to us. We also had a need to audit and evaluate the success of any of the PBS plans that we'd implemented. It was also noted that the approach adopted varied, again, from team to team, and there was a need for far more consistency and to communicate the PBS approach on the ward. Not all the consultants had received the training, it's probably accurate, and again, it was still clinical judgment, 50-50, you're going to get it right, 50-50, you're going to get it wrong. It wasn't scientific enough. So at this point, Dr. Davies joined the clinic, thankfully, initially on a 0.5 full-time equivalent status or part-time, specifically to help us develop PBS within the clinic. We revisited a core PBS implementation group which was set up, which involved the ward managers of Penarth Ward and Tenby Ward, myself and a colleague, our psychology department, obviously Bronwen, OT, multidisciplinary, sort of a senior level, just to reinvigorate what we were doing. Group set its function, so it was review and agree the assessment tools to be used within the clinic, consider the PBS training needs and plan training dates to meet the needs. So again, reassessing and redeveloping our training. Agree the process of how that was going to work. So, and the key point then was identifying our potential service users approach for PBS and to monitor their progress. So it's pointless just doing this if we then don't know and specifically try to adapt this to the people who need it and will benefit from it the most, hopefully. Develop service user information. You know, throughout this, I have to emphasize how much time we've spent and effort, absolutely quite rightly, involving our service users in this, in terms of our community meetings, our ward meetings, our user-friendly groups, the one-to-one time that Bronwen and people in her department have, our primary nurses, all the IPBS care plans when they're developed, you know, the service user-led, they're absolutely central to them. Probably still room for us to improve upon that, but it isn't just tokenistic in us saying that, you know, it is central to that person, their say on it, how the care plans are written is from their perspective and it's their words, so that really is central to what we do. And going back a couple of slides, again, addressing the barriers to implementation, chiefly staff attitudes. We liaised then with our own health board's R&D department, so we identified whether projects could be considered as service evaluation or were they research-led, which would then need ethical approval. We looked to evaluate the effectiveness of the PBS within the whole clinic and agree the process for that. We're looking to evaluate the training and review and adapt as necessary. All that feedback went through to our senior management department, so our clinical lead department, our psychotherapy coordination group, our nurse practice development forum, our team meetings, our service managers, to name but a few. So it was in the air that we were trying to breathe within the clinic. It was at every level we were trying to saturate it. The plan then is for the dissemination of results. So we're looking at, obviously we're here today at a conference to share some results. So that's one part achieved, and thank you. And we've had one article published already, and we're looking, well,
we're in the process.
We're in the process of creating others. So there we go. What we've also been very fortunate to do is network with our own learning disability department within ABMU. They've been key in supporting what we're doing, and Bronwen can talk more about that afterwards. And we've also managed to forge links with external forensic services. There's Tayside up in Scotland, we've got links with them. Ardenley, Women's Secure Service in Burnham, got links with them, and others across the country. So within mental health, we're developing hopefully a little bit of a network where we can sort of compare and contrast and share results and our outcomes and try and learn from each other. So where we are now. We've redeveloped the training resources, and we've provided that to nurses, OT psychologists, and anybody else who will listen and sit still long enough for us to train and educate them. We've managed to undertake full day's training to qualified staff, half a day training to unqualified staff, and to date all the staff, so qualified and unqualified, and support staff for our two most acute male wards have had the training. The staff from the other wards, the continued care, continuous assessment, rehabilitation wards, they're working their way slowly through the training, and our qualified staff are being supervised and supported through their first functional analysis and IPBS plans. Very recently, it's also been agreed that PBS will now be implemented across the whole clinic, which takes into account, as much as anything, the women's service. As I said, It's part of our clinic, but it has a dedicated team, whole dedicated clinical team, and in essence, it is the most challenging ward in our whole clinical environment. It's the ward that generates the most incident forms, it's the ward that generates the most deliberate self-harm, it's the ward that generates the most destruction, so it is the ward that hopefully will benefit the most from this. So we're right on the cusp of introducing that to that particular clinical area.
Is that instead of DPT then?
As well as.
As well as,
As well as.
yeah.
Yeah.
Yeah, I mean, the brains of the operation can talk about that. So our functional analysis tools have been introduced to complement our ABC charts, and these are included in the training that we provide for our qualified staff. And they are the contextual assessment inventory, the brief behavioural assessment tool, or the BBAT, and service user assessment tools. We've developed and implemented the individual PBS plans, the IPBS plans. We have 7 live plans, so 7 of our patients have gone through the whole assessment system, have gone through having the functional analysis undertaken, and we've got 7 live plans. 3 more are underway in the men's service and not far off being ready to go. And on the women's ward, so far, out of there's 11 beds, is currently we have 10 female service users there. We have 5 identified, hopefully would benefit from the PBS system around them. The IPBS plans were developed within our own ABMU, Abertawe Bronwen University Health Board, if you need to know what it is, Learning Disability Service. And as I said earlier, it's the service user's perspective, it's their narrative, it's in the first person. When I first read an IPBS plan, in 20 odd years of nursing, it was probably singly the most powerful thing I've ever read, which I'm not ashamed to say that. Having somebody's life story written fully in their perspective, this is me, this is my story, these are my challenges, this is what I find helpful, this is what I don't find helpful, was just a fantastic revelation. And no matter what we've done, I wanted that ethos built into our care planning, what we do with our service users, and how we represent or help our service users represent themselves. The effectiveness of our training has been assessed by measuring staff confidence in managing challenge behaviour and their understanding of attributions, both pre and post training. The effectiveness of our plans have been measured using an adapted challenge behaviour checklist. Senior clinicians are involved in the training, so we've got an increased consistency of approach. All the psychologists have been through the training. We've got all the medics lined up to go through the training. The senior nurses have been through the training, so we're far more consistent in our approach to delivering the PBS system. We've received Research and Development Department agreement to complete 4 service evaluation projects in relation to the implementation of PBS within the clinic, and we're in the process of writing up the paper on that. So in terms of the PBS process within our clinical areas, we just flow down from the top, complete the baseline assessments for the challenge behaviour checklist and the file review, undertake the functional analysis using the BBAT, the CAI, client assessment tools, and the ABC charts. We interpret our assessments, so we're identifying slow and fast triggers and the maintaining functions of those behaviours. Meeting them with psychologists, the nursing team, occupational therapy, and we agree the interventions. And then the key point, again, is at the bottom of that flowchart, we meet and agree this with the service user. We bring back our understanding, what are their perspectives, what do they want the plans to represent of them, sit down, write them with the person. If they're unable to articulate in terms of their literacy, they're writing themselves, we will transcribe what they say. Just listen, they talk, we write. That becomes, the key concept of the IPBS plan.
And the client assessment tool was developed to include them in that part of the process as well. So they're involved throughout, really.
Again, just a quick flow chart of our own process for service evaluation. So we're completing the baseline assessments, the CBC, delivering the training. Offshoot, we're evaluating the training, confidence attribution, styles. We'll follow that up in 3 months, write that up. Again, going back to the main chunk of the work then, our primary nurses complete the functional analysis, meetings with the multidisciplinary team, the wider clinical environment to agree, write up the plans. Again, the key part, we agree with the service user, we implement, we communicate, we discuss with the team. revisit the challenging checklist after 3 months, see if there's been any progress and what we can learn from that. Again, key point, we interview the service user regarding their experiences of PBS, their lived and learned experiences. What does it help? Maybe what hasn't it helped? What can we learn together? And write up that as an evaluation. Is this where I step aside, or I got a couple more?
It's just about the evidence base. I don't mind taking it.
So, just the research starting out, just to back up the evidence base for our training and for what we've managed to achieve. So I'll just do a couple of slides, and Bronwen's going to take over with the results mainly. So increasing staff confidence in managing challenge behaviour acts to increase levels of proactive and therapeutic intervention whilst ensuring the safety of the service users and staff. I like Martin and Daphne for the reference on that, just showing why we're doing what we're doing and why we're trying to really evaluate what the training's achieved. Where confidence then in managing or addressing challenge behaviour has been measured in relation to forensic or psychiatric staff populations, the training provided has tended to focus on physical interventions and legal considerations as opposed to positive behavioural approaches. So not a huge amount of evidence we could find specific to our environment and our care processes. Or the confidence has been measured more generally as opposed to a specific outcome measure of the training. So we're trying to measure confidence specifically as a result of the training that we've gone through. Again, 87 Thackeray's work training did include the principles of psychological assessment and intervention. However, very little detail was given to what these involved. So, just a question whether punitive approaches advocated. The research into the impact of PBS training on staff confidence in managing challenge behaviour has been gathered from learning disability staff samples. Again, nothing that we could particularly find around our own clinical experiences, our own clinical environment. Lowe et al. In 2007 found significant increases in staff reported confidence in dealing with challenging behaviours after training. So whatever training was delivered, there were increases in confidence. And T&E in the same year, 2007, showed clinically meaningful increases in self-efficacy after training to promote understanding and responding to challenging behaviour. That was maintained at the 3-month follow-up. Another method that has been employed, in assess the effectiveness of training in PBS is measurement of attributions for causality, control and stability of challenging behaviours and the degree to which they change after training in PBS. Weiner's work in 1980 found that ratings of help were lowest when behaviour was viewed as internal and controllable, which engendered feelings of disgust and anger, in contrast when behaviour was viewed as external to the person. And uncontrollable helping behaviour was elicited as a positive effect, such as sympathy. And that, in itself, that very last part I have seen time and again in the training that we've delivered to our qualified and unqualified staff. And it goes back to one of the first slides about there must be a consequence, they're getting away with this, they're manipulating me. It's just not understanding where those challenging behaviours are coming from that person's experience at the centre of it. And just at a personal level, that is one of the key components for this for me, is helping our staff, my colleagues, understand where challenging behaviours come from and their attributions towards care within that is one of the absolute key concepts. On to the results now. I'm going to hand you over to Bronwen, so you can probably explain it far better. Oh, you can carry on.
All right. Sorry.
I built you up now.
Okay. So in terms of attributions then, in a forensic population, Reed and Millard demonstrated that staff believed service users were less treatable and less likely to positively engage in care if they believe the service users to have a high degree of controllability and stability over their actions, so they had control and they weren't going to change. And obviously subsequent offending behaviours. Also, Sharrock et al. In a media secure service showed that helping behaviour was generated from either sympathy or anger towards another person, which in turn was derivative of how the individual perceives and understands the underlying reasons behind acts of challenging behaviour. So in terms of the impact of PBS training, again, this has mainly come from a learning disability staff population. Lowe et al. In the same paper actually, found that changes in causal attributions of challenging behaviour measured using the CHABA, the Challenging Behaviour Attribution Scale, sorry I have to check it, immediately following training sessions for both qualified and unqualified staff, but this was not maintained at 1 year follow-up. Davies et al. In 2007 found an increase in accuracy of staff attributions after PBS training. However, the evidence regarding the ability of training in PBS to modify staff attributions has been mixed and inconsistent. So papers like by Mackenzie et al. And Tierney et al. Found no significant changes. So in terms of our training evaluation, this was done at the point that 79 staff have been trained from a psychology, OT and nursing background. Qualified staff training, 48 qualified staff from those backgrounds attended, and there were 31 unqualified staff. So in terms of the confidence, we introduced this a little bit later, so the numbers are less in terms of degrees of freedom, people noticed, but there was a significant increase in confidence in working with people who present with behaviours that challenge after training in PBS. There was also, for the qualified staff, there were significant increases in attributing the cause of challenging behaviour measured by the CHABA to the physical environment, stimulation, learning, which is broken down into learn positive and learn negative, biomedical and emotional reasons. So there's a more understanding about where challenging behaviour was coming from. And there were significant increases for the unqualified staff, not on all the measures, but on physical environment, stimulation, learning, learn negative and biomedical.
Okay.
Yeah. So the causal dimension scale, the CDS, measures varies around local causality, control and stability. And significant changes were observed in this in relation to the qualified staff, but not the unqualified staff. So the qualified staff showed significant reductions in locus of causality. And in that sense, it means there was a reduction would be the degree to which the behaviour caused by the person or the environment. So lower scores reflect more of an environmental cause, so recognition that the causes could be much more environmental as opposed to internal to the person. Stability, a reduction would show that it's less stable and more changeable. And personal control, there was a reduction. So that means that reflects less controllable by the individual. Okay. So the changes in scores were significantly different between qualified and unqualified staff. Qualified staff made significantly more of a reduction in attributing the locus of causality to the individual, increasing the attribution of causality to the situation than unqualified staff. And similarly, more significant reduction in challenging behaviour to be stable and unchangeable compared to unqualified staff. And some of the reasons we thought that might be around is perhaps the education and background that the qualified staff brought to the situation beforehand, but possibly as well in terms of what we were teaching people. So in the qualified training, they were given much more information about function analysis, you know, what to do, how to do it, the tools, but also they were given a lot more information around primary prevention strategies and what was possible. So perhaps giving those tools change those viewpoints in terms of stability and causality. So in terms of the evidence base for positive behavioural support itself, in the UK, it's very much around people with learning disabilities, and in America, in the States, it's much more around child and adolescent populations. There's currently no evidence base in relation to forensic mental health population. However, being based on behavioural approaches, you know, it is recognised that there is utility in a much wider context than it's currently used, and that's Alan quoted that. In Learning Disability Services, McLean et al. In 2005 examined longitudinal outcomes of 138 PBS plans and found significant improvement in behaviours in 77% of cases at an average follow-up of 22 months. So good improvements in learning disability services. And in the States, school-wide PBS systems have shown reductions in challenger behaviour between 20 and 60%. So that's Curtis et al. So obviously it's very early days for us, and plans haven't been, there's only 4 plans that have been in long enough to re-evaluate. So 4 plans we've implemented, re-evaluated after 3 months in situ. Now we've used the challenge behaviour checklist, but we've added a couple of things in terms of forensic population, in terms of kind of antisocial attitudes, like voicing kind of misogynistic beliefs, pro-paedophile beliefs, etc. with peers, and the other thing we added in, I can't remember, but there was one other thing we added in anyway. But we adapted it for use in forensic services. And decreases were observed in the frequency, management difficulty and severity of challenging behaviours. Yet at the moment we obviously haven't got enough power to analyse statistically. So that's the 4 service users in terms of frequency. So you can see there are big drops in behaviour there, and that's management difficulty and severity. But obviously these are very small numbers. So, but they're all going in the right direction, which is good news. Still very small sampled. Data collection is continuing. Yeah, we've been told we're linking in with Swansea University, and they've advised us we need to get at least 20 up and running and re-evaluated. So.
Data from service users before PBS?
We've done the baseline, and then we've done the PBS, and then we're evaluating.
Yeah, but I mean, have you got, because that looks good, doesn't it?
Mm-hmm.
But I wondered if, without the PBS model, like...
The treatment as usual.
Anyway, yeah, like what's the incident rates for people that aren't?
We haven't done that, but it's certainly something we can...
So you can figure out whether it's PBS.
Yeah. Those behaviours over, so and when you've got the tools to go in and actually work with them, and in practice, based evidence is where we're coming from with this, having that kind of more control group, I think would be more difficult.
I know we've got only got about 30 seconds, so we did have a case study to find through, we'll probably just skip that. There is evidence, I can't draw it out right now, but there is evidence of people, of the same people who are now on PBS plans who worked and what their behaviours were was significant. One of those was the case presentation, just in terms of it's very pro-criminal, very authoritarian, misogynistic attitudes. And they were in situ, and invited them to say, we then introduced PBS, and there was a change. So that's sort of the best we can do, because...
But we haven't measured it. We haven't done a measurement of like 3 months prior, for example. It's accessing media secure units outside of our own as well. So, because I mean, PBS is not well used in forensic mental health, so I guess there would be control groups there. So I mean, it might be worth thinking about and accessing. Well, this is, I mean, just to skip past the thing episode about friction.
Yeah.
I mean, in the future, I mean, this kind of in the future, this is not one of the things we really need to think about. Obviously, we're going to finish training all the staff in the clinic with an ongoing programme. We're training all the medical staff because they've become really engaged, because they've seen changes in the service users since it's been implemented. So they've actually asked us to come over and train them, which is great. We're doing a qualitative study about people's service users and staff experiences. We're looking to re-evaluate attributions, confidence, and continue to evaluate data. And obviously the outcomes are maintained and continue to show a really positive effect. We're hoping for business plans to get people trained in PBS within the clinic, hoping some publications, developing review frameworks, and consider how PBS impacts on long-term changes post-discharge recidivism, how to reduce relapse and promote safe transitions. So in learning disability services, there's a lot around person-centred planning being included in the PBS plans. And I think in our services, we're more integrating the recovery model and where people are now and where they want to get to. looking at their own motivations, his strengths, and doing it that way. So, but it's trying to give them the skills, or enable them, facilitate them to develop the skills to be able to take forward into the community when they need.
I'm sorry, just to pick up on a few things, and I think the lady trying to think. There's one way of looking at things in terms of control groups and intervention and that, but in some ways you might not be able to prove that that's possible, in the sense that we would be in single cases, deal with individual cases. So it might be interesting to look, if those cases are the same people, to look back at the last few months before you start doing it. But then also start to think, if you get caught up in this idea that you have to do control group interventions, then of course that's a move down the strength evidence route. But initially, if you're thinking about developing evidence, it could be on single cases, and it could be the way of starting to take data before you implement evidence. So you mentioned the email service that you were starting. Presumably you've got data already from individuals.
So there could be
a possibility of doing multiple baseline cost assessments or across populations. So there are different ways of looking at
the
research.
Behaviour checklist does do that kind of reflection back over the last year. So in terms of that, it does look at that, the baseline assessment in terms of the previous.
Yeah, but prior to baseline, if you've got historical data, you can see the effects of treatment as usual as you could there. And then you implement your DES, you've got the baseline, you've got time 2. The baseline is time 2, essentially you've got historical data. But now you can be proactive in the sense of looking at people who haven't implemented DES yet as a baseline for their own data, so they're in control for themselves in a sense. This is what they do before DES, this is what happens after DES.
Yeah.
It's an A/B design, so it's not particularly strong, but it is building some evidence that they could start leading to be thinking about, well, no, we need to find control groups.
Just conscious of time for that, sure.